switches. Yeah. So I'm supposed to talk about early pain control, evidence-based approaches, and practical challenges. So there are two components to it: evidence-based, what is the approach for pain management in acute pancreatitis, and then what are the practical challenges that we talk about. So I'm not going to go into the details of how acute pancreatitis behaves. We all know, I think Ashish has spoken brilliantly on this, that in the first 2 weeks we have the systemic inflammation, SIRS, leading to early primary organ failure, and in the beyond 2 weeks we talk about infected pancreatic necrosis and its complications. So whenever we talk about a first week management or the first 2 weeks management, we talk about four predominant things, right? One is the prediction model, which I think Ashish have already spoken about. Then there is pain management, fluid management, and finally how do you feed the patient, right? So I'm going to talk about pain management. So when we talk about pain management, we need to understand the pain. The patient comes to the hospital with pain. So pain abdomen for acute pancreatitis is the symptom with which the patient is coming, is the symptom because of which the patient is troubled. And obviously because it's so important, because it forms the diagnostic criteria for clinical diagnosis. But the problem is that when you talk about pain management, there is a lack of definitive guidance or consensus. Even when we talk about WHO pain ladder being used for pain management, how relevant it is. In the next 10 minutes, I'm going to talk about what is the status now. So this is one of the very elegant papers that recently came up from the Hungarian Pancreatic Group, where they kind of tried to characterize the nature of the pain. So while trying to characterize, they said it was cramping pain, dull pain, or sharp pain, and they tried to find out if the nature of the pain differed, whether the severity was differing or not. They found out that sharp pain was associated with more severity, increased mortality, etc., whereas long-standing pain was not correlating with any of the outcomes. So this is a very elegant paper where they kind of try to characterize the pain, nature of the pain, and the severity of the disease. So whenever there is a pancreatic injury, what happens is there is a disrupted calcium homeostasis. I'm not going to do the details. There is an NF-kappa B activation, trypsinogen cleavage. So once the NF-kappa activation happens, pro-inflammatory mediators get released, activated, it then activates the pain factors, and at the same time when there is a trypsin activation, there's a lot of inflammatory cell infiltrate. Again, a lot of substance P, CGRP gets released, which again perpetuates the whole pain mechanism. Right? So when we talk about this pain mechanism, this is happening at the cellular level. So that is the first part where what happens is at the peripheral nerve terminal, there's increased release of ATP, trypsin, H2S, nerve gas, NGF factors, which starts the initial noxious stimuli. And as it goes down to the dorsal root ganglion, it transmits the pain. There is a pain transmission going up to the brain, causing the kind of pain that the patient experiences, right? So look carefully into this image. What you find over here is, this is the part where we talk about the nociceptive part of the pain. So where it happens exactly at the cellular or the acinar cell level. And then it goes to, when it goes to the dorsal root ganglion, it's the neurogenic inflammation we talk about. These two are the primary factors which acts upon when we talk about acute pancreatitis related pain. Obviously the neuropathic component of the pain doesn't usually happens or does not get enough time to happen in acute pancreatitis. So this was one of the very recent papers from Sanjay. He had published that with, we always want to understand whether pain intensity has something to do with the prognosis of acute pancreatitis or not. And they found out that yes, if there is severe pain or moderately severe pancreatitis or severe pancreatitis, more pancreatic necrosis, the patients are supposed to have more pain. So that is how the pain intensity goes hand in hand with the severity of the disease. So whenever we talk about any principle of pain management, any pain on this planet, we talk about these components on which we treat the patient: the sensory component, the cognitive component, the emotional component, and the social dimensions, right? So this is the whole holistic approach of management of pain. Obviously, when we talk about acute pancreatitis, the cognitive, emotional, social dimension does not tend to get developed. We talk about is the sensory component of the pain where we manage, because that we need to decrease is the intensity of the pain. And we have always been talking about, whenever we talk about pain management, we talk about the WHO ladder, right? When there is a mild pain, you give NSAIDs or acetaminophen adjuvants. When there is a moderate pain, you give weak opioids with or without a non-opioids or adjuvants. And when there is a severe pain, you go with potent opioids along with any other additional non-opioids or adjuvants. And when we talk about pancreatitis, we do not talk about any mild pain. The patient is having severe pain. So predominantly, we are talking about a moderate pain to severe pain. Now, we need to understand that whenever we are applying WHO ladder to everything, including acute pancreatitis, we need to understand they talk about a step ladder pattern where you go up from one which is not effective to one which is more effective. But a patient who has come to and landed up in your emergency, that patient demands immediate relief of the pain. So it's more of a top-down approach rather than a step ladder pattern of a pain. So that is where the relevance of WHO ladder pattern in acute pancreatitis pain management becomes slightly dubious. So let's see what are the agents that have been used for pain in acute pancreatitis. So there are multiple studies that have been done on various agents. So obviously we start with standard agents like paracetamol, acetaminophen. We move to local anesthetics have also been tried, like procaine, lidocaine, bupivacaine, diclofenac, indomethacin, etc. From there we have opioids, obviously the stronger and the weaker opioids. The weaker opioids being tramadol, the stronger opioids being pethidine, fentanyl, buprenorphine, and obviously epidural analgesia. Whenever we talk about all these various medications and therapies that have been discussed about in pain management, two important components of pharmacological agents come very, very prominent: the NSAIDs versus the opioids. So let us see how do they have their pros and cons. Like NSAIDs, we talk about they have anti-inflammatory properties, reduce the AP-related injuries probably, but obviously they have their GI and cardiovascular side effects, and they have a lower analgesic potential as compared to something like a strong opioid, where more potent analgesia, they have a post-drug analgesic effect, but obviously they have their own side effects like abuse potential, respiratory depression, and some of the opioids can even increase sphincter override pressure. So if we look into the evidence, which was the first part of my talk, of the various agents that we talk about, non-opioid analgesic we talk about like paracetamol or acetaminophen, questionable efficacy. They might be probably acting in very, very mild acute pancreatitis, but not, and they are acting more as an adjuvant to any other agent that we use. Coming to NSAIDs like ibuprofen, diclofenac, and recently the paracoxib or the COX-2 inhibitors, obviously they are efficacious, but obviously they have the GI and renal effects that we talk about. Coming from there to weak opioids like tramadol we talk about, how efficacious are they? This was one of the papers published from our center where we compared between tramadol versus diclofenac, and we found that both of the agents are equally effective. So meaning thereby that tramadol is as good as diclofenac or vice versa. So meaning thereby, yes, tramadol is effective, but is as effective as only the NSAIDs. It obviously can be used or to help potentiate non-opioid analgesics as well. Moving from there to stronger opioids, like we have been using morphine, but then we use fentanyl, buprenorphine, pentazocine. What is the data on that? Obviously, Soumya published this paper way back in 2019 where he had kind of compared between diclofenac and pentazocine and showed that pentazocine was working better than diclofenac. Points to be reminded over here is that whenever we talk about any pain management protocols, it's not only the VAS score or the NRS score that should be taken as a surrogate marker for pain relief. One of the important marker is patient control analgesia and seeing how much amount of rescue analgesia is required. So this was one of the studies which has kind of very initially used the patient control analgesia. They showed that yes, pentazocine was working better, or an opioid was working better than diclofenac. From there, we move to one of the studies that we published a couple of years back, where we compared between buprenorphine and diclofenac, and we showed that obviously buprenorphine performed way better than diclofenac, and they performed better even for moderately severe and severe pancreatitis, which we were talking about just a while ago, where the pain intensity is supposed to be greater. Also, we used the patient control analgesia in our study as well. So if you go from these two particular studies to the meta-analysis that was published recently, they showed that within 24 hours, NSAIDs were equivalent to opioids, but beyond that, opioids are a very, very good analgesic. They're as good as an epidural analgesic and better than local anesthetic or NSAIDs. Then what are the concerns? We have an answer, right? We have opioids. So what are the concerns for opioids in acute pancreatitis? The first paper came up in 2017 from Professor Saluja's team, and they showed, tried to show in mouse model that morphine exacerbates neutrophilic infiltration and necrosis and probably worsens the course of acute pancreatitis. This was followed by another rat model study published in 2022, where they said that the type, dosing, administration route, and the timing of opioid may probably influence the AP severity. So we still do not know whether the opioid is actually worsening the acute pancreatitis, or it's the other way around, that more severe pancreatitis require more severe analgesia, because of which there are more use of opioids. So this was a pain AP database that Sanjay had led from Newcastle. We were a part of it, and we found it was involving a prospective data of 118 centers, 27 countries, almost more than 2,000 patients. And it was seen that the opioid prescription was variable across continents, with higher use in Asian and Australian centers. And obviously more and more patients who had increased pain, longer pre-admission pain or organ failure had higher opioid prescription naturally, because probably their pain is much, much more greater. And obviously there was some hint that probably opioid administration was higher, had a higher risk of moderately severe acute pancreatitis or severe acute pancreatitis. And when there was a more than 40 milliequivalent doses of opioids, there was morphine equivalent doses of opioids, the increased risk of moderately severe and severe acute pancreatitis. But whether it was the other way around, we do not know. This was a derivative of that post-hoc analysis of that paper, where we found out that there was no association with daily IV morphine equivalent doses, meaning thereby that probably this was more of a confounding and reverse causation bias likely. So more likely that severe pancreatitis will have more pain, because of which the opioids requirement was higher, and not the other way around. So if you look into strong opioids, yeah, they're more efficacious, but obviously there's an abuse potential, and we still do not know about the impact on the severity. Moving from there to epidural analgesia, obviously the systemic review and meta-analysis published, which shows of 9 studies published in 2022, where we found that yes, epidural analgesia was pretty safe and efficacious, and it was seen that the ventilatory support was lower in patients who are undergoing epidural analgesia, probably because they had much better pancreatic perfusion. And obviously this was safe and efficacious. Obviously there was caveats to it, like development of transient hypotension or epidural abscesses. Followed after that meta-analysis, this EpiPan study was published, where primarily the outcome was to try to find out whether the number of ventilatory-free days was lower or not. They found no, there was no difference. But again, this paper was not designed or powered to look whether it was much more efficacious as an analgesic or not. So obviously for epidural analgesia, yes, it is efficacious as an analgesic, but obviously there are issues like catheter-related hypertension, abscess, and obviously it might not be available at all centers and at all times. Moving from there, what are the alternate options that we talk about? So we have talked about the usual options, then we talk about acupuncture, transcutaneous electrical nerve stimulation, and then there are newer opioids, NMDA receptor antagonist, magnesium. Again, the evidence is very, very low. Acupuncture, you will find, is a traditional Chinese technique recommended, in fact, by the consensus on AP management of Chinese medicine. And it is said to improve GI motility, GI function, treat abdominal pain. Even a recent randomized controlled trial was done on this, but however, they did not find any difference as far as the pain reduction was concerned. But again, the problem with acupuncture is that everything is Chinese data. There is nothing outside China, the data is available. So we do not know exactly how to. So as long as I've been discussing about pain, what are the knowledge that we have? We already know that NSAIDs and opioids are equally good for mild acute pancreatitis. Opioids have better analgesia potential, maybe better in moderate severe and severe acute pancreatitis, and opioids have been used non-uniformly. What we do not know, there are more robust data is needed as to which opioid to give. We still do not know about that. Does it worsen the disease? We still do not know. What duration is safe? How long do we give it? And what are the other modalities of pain management that will be as well effective? So what are the challenges? So first part is evidence, I've already kind of covered. Now what are the challenges that we have whenever we talk about pain management, optimizing in the future, research in the future? So the most problem is pain trial design, addressing the actual problem and the lack of interest or collaboration among the stakeholders. One of the recent papers that have showed that one of the key unmet needs for acute pancreatitis was how to tackle or treat acute pancreatitis, pain management. But again, it lacks that because the pain trial designs that have always been done, there are certain key issues. One, there are multiple small trials, very, very small sample size are there. So it never reaches the power that is required to actually answer the question. There's a variability in outcome assessment, outcome parameters, timing of assessment, everything is variable. What is a true outcome measure? What is important for the patient? Does a VAS score or an NR score or just a rescue analgesia defines that the treatment is efficacious? We still do not know. We need to define much better. There's a lack of collaboration among the actual stakeholders. If you look into the papers, you will find either it's a gastroenterologist doing or a pain intensive is doing, but none of them are collaborating with each other. And obviously, there's a lack of patient-public involvement. So these are the major issues that are there with the pain trial designs, and we need to kind of collaborate with each other, try to get better trial design. And finally, are we correctly addressing the issue in pain in acute pancreatitis? Whenever we talk about pain in acute pancreatitis, we put everything in one bubble where we find out nociceptive pain, neurogenic inflammation, visceral pain, neuropathic pain, and we think NSAIDs and opiates are going to take care of that. Really? What about ascites and fluid collections developing, which is again contributing to the pain? The ileus that is developing, the mesenteric inflammation and bowel ischemia, the intra-abdominal hypertension, everything is contributing to the pain, and we think just treating by NSAIDs and opiates is going to tackle the pain. It's not going to happen like that. So when we start judging for the evidence to frame the guidelines, this is how frustrated we are. And I'll just give you a brief of how the AP guidelines have been doing about pain management. You see AGA, BSG, Japanese guidelines, ACG. If you look into their data, their detail into the guidelines about what they talk about pain management, 3 of the 4 guidelines are numb. They're silent about pain management. Japanese guidelines only just comment, they did not even recommend that non-opioids should be given followed by opioids. I'm thankful to IIP, APA, this joint guidelines that have just come up this year. They said that opioids or NSAIDs should be used and opioids provide better pain relief. They have come up with a recommendation, but again, the quality of evidence is still moderate. So at the end of the day, again the same question. The patient has come with pain and it's going to ask you the same question, that why are we still not able to achieve that pain management adequately and optimally yet after so many years of tracking with pancreatitis, and we are still a far way to go from understanding this problem. Ladies and gentlemen, I'll finally kind of give a brief pragmatic approach probably for pain in acute pancreatitis depending on the data and the guidelines. that whenever a patient comes with pain in acute pancreatitis, give some NSAIDs, PCM, assess the severity of the pain or disease, use a patient-controlled analgesia. If there is mild acute pancreatitis or the pain score is less than or equal to 3, probably weak opioids with or without some additional adjuvants will help. If it is a severe or moderate severe pancreatitis, you should consider strong opioids like pentazocine or buprenorphine. And obviously, if it is available at your center, you might try for epidural. Anything can be supplemented with IV fentanyl as a top-up dose kind of a thing. If weak opioids do not work, you can go in with strong opioids, and everything fails, you can look for other causes of pain. Look for these things, treat them, probably you can help the patient better. Thank you.